All right, good morning, everyone. My name is Zika Tan. People know me by Owen. I'm a sub-I on neurosurgery this month. So I'll be talking about oxygen sensing at the closer of cancer metabolism detection. Okay, so the first project I'm going to talk about today is the detection of long non-coding RNA Cohort in GBM. So GBM, as you all know, is the most aggressive and common adult brain tumor. The um, treatment now we have is surgical resection followed by radiotherapy and temozolomide chemotherapy. And the 5-year survival rate is very low. So many years ago, we published a study showing that this long non-coding RNA called Cohort is specifically expressed in GBM. Is highly, as you can see here, is highly expressed in GBM tissue as compared to normal control. Normal brain is not detected at all in the adult brain region. So what is long non-coding RNA? As we all learn in biology classes, that central dogma of biology, the DNA encode for encode for RNA, and then that encode for protein. But after decades of research, they have shown that it is actually not true because only 90%, less than 10% of the RNA encode for protein, and majority of the mRNA they are actually not coding for protein, and this is called the non-coding RNA. And Cohort is one of the long non-coding RNA. Cohort, its full name is called Hox antisense intergenic RNA. Um, so a lot of research has been going on. What's the role of long non-coding RNA? People have shown that it could regulate gene expression in both tumor suppressive, also oncogenic pathway at epigenetic, transcriptional, and post-translational level. And important for me is that this Cohort is actually hypoxia dependent. So just in the previous report that we show Cohort is expressed in the tumor cell, but our next question is whether Cohort can be used as a biomarker or serum biomarker for GBM detection or as a use for prognosis prediction after treatment. So in order to do this, I started a project to collect patient sample at UMBTI and also from Florida Center of Brain Tumor Research, where we look at where we detect this long coding RNA Cohort in the patient's serum sample. So 3 years ago, we managed to publish this data showing that, as you can see here, in Cohort is actually detected at much higher levels, significantly higher in GBM patient serum as compared to the normal patient. Also in this figure, you can see. And also it comes with a high sensitivity and high specificity. Next, we also do the pair comparison between the paired tumor tissue as well as the patient serum to show that whether there's a correlation between the Cohort level, and show that there is actually a correlation of Cohort in tumor as well as in the serum, meaning that the Cohort that we detect in serum is actually coming from the tumor tissue. Research has shown that this serum exosome, which is microvascular, has important role for cell-to-cell communication. So our question is that whether this Cohort that we detect in the serum is actually contained in the exosome. So in order to do this, we purify the exosome, and we managed to show that this Cohort is actually enriched only in the exosome, but not in other part of the serum. And we also do a nanosite analysis. Basically, it's just an analysis to show that the exosome that we purify actually contain the Cohort, and these bright little dots are actually the exosome that we see. We also show that not only in the exosome that we can detect this Cohort, but also we can detect the Cohort network, because Cohort is actually encoded by a superfamily called Hox, and we managed to find other long non-coding RNA in the exosome, because one biomarker may not be sufficient. We want to have a collective of different biomarker that can be more prognostic. In the same paper, we also have a very small supplement figure showing that we follow a patient that's treated at University Miami Hospital, and show that this Cohort level progressively decreased from pre-op to post-op and 2 weeks follow-up. So I remember there was one time Ashley told me, it's like, oh come on, and this is just one patient. How is that really significant? So then our next step is actually trying to look at this result in a bigger population. Um, so we are also approached by radiation oncology that they would like to expand this data to look at something called true progression or pseudo progression. Um, so as we all know, after the treatment surgery for GBM, patients usually undergo MRI stimulation about 1 month after surgery, and I have radiation therapy for 6 weeks, and then there will be another follow-up MRI about 1 month after that. So altogether in 3 months. This one patient, this shown here, this in red area showing that there's a high dose of radiation in this view at the beginning of the surgery. Um, but after the radiation therapy, we see that there are multiple new nodules in the in the radiation field. So the question is that whether this is actually a true progression or actually pseudo progression. True progression meaning that there's actually a treatment failure and the patient continued to do um, worse after the radiation therapy. Pseudo progression is actually just an exaggerated or immune response to the microscopic tumor on MRI without actually a true progression of the tumor. So if there's, why is it important? Because the early identification of the disease progression um, can actually means that the um, true progression has worse prognosis. So as you can see here in the blue line, which showing pseudo progression, they have good survival about 35 months after radiation therapy. But in the yellow line, sorry, in the gray line, there's a true progression. The patient only have 7 months after radiation therapy. So the goal is actually to re-stratify this GBM during radiation therapy to adapt the radiation for high-risk GBM because there's just very little time. We want to, so in order to do this, they started this daily multiparametric MRI for GBM. So we collect the patient blood before surgery, during radiation therapy, weekly, and also follow up. And they also do MRI daily in this patient when they receive radiation. Um, Currently, there are 14 patients included in this study. Um, and one of the results that we have showing that this during the treatment, you can see that there's a progressively increase in the size of the tumor. And out of these 3 of the 4 patients that they analyzed, there's a delay increase in the size of the tumor as compared to the early increase in the size. The hypothesis is that the delay increase in the size is more of a pseudo progression type, but rather than a true progression. And our role here is to see whether hot air can used to predict the early growth of the tumor, which is the true progression, and thus better correlate with the tumor growth and help with better planning of the radiation. If we manage to detect this hot air early in the phase of radiation therapy and looking at the size, it's actually a growth of the tumor, whether we can do something, do a change to the radiation dose and help with treating this more aggressively. All right. So now just gonna spend 1 minute to talk about my PhD projects that we published early this year. Um, so instead of going through all the figure, I'm just going to tell you a summarize of the data. Is that we all know that fat is a risk factor for tumor, and we show that this hypoxic tumor and so fat cell that secrete this adipokine called camerin that act in autocrine and paracrine pathway. This camerin can actually regulate different species of the lipid that can upregulate HIF pathway that suppress fatty acid oxidation for lipid droplet formation and thus promote tumor regenesis. And if we can target camerin using monoclonal antibody that we develop, we can actually target this pathway and increase the fatty acid oxidation and causes some mitochondrial defect in the mitochondrial complex defects and thus increase this lipid oxygen species that actually ultimately causes ferroptosis, which is a new type of cell death that we described in the cell. And my next step is trying to apply the same concept into IDH mutant GBM, just because of the similarity between the model that we looked at previously and also in the IDH mutant GBM, because it has lipid metabolism, using the same pathway, reductive carboxylation. They have the HIF VHL pathway, which we previously looked at, and also the ferroptosis pathway. So in the meantime, I'm trying to develop this IUE model for IDH mutant GBM, the syngenic model for this tumor. And some preliminary data that I'm ready to probably apply for new grant. Also, hopefully, can continue doing my research here during residency. Also, hopefully, they will be used for my own R1 in the future, just because we got the R1 for the same project that we just published. With that, I will end, and I would like to thank all the everyone here and listed on the acknowledgement page, and also thank you for everyone for giving me the chance to share my story today. Thank you.
Oh, and that's incredible, and thanks for stepping in at the last minute. I mean, those publications are really super high impact. So congratulations. So this is a little bit, next slide, about an out of the mothball type talk, although we do have some new data that I wanted to share with you, some of which is from Aditya, who is our fellow last year, who did an incredible job with some of this work. Next slide. And so, you know, basically, as you know, the corticospinal tract is the preeminent motor tract in the human, and depending on what subspecialty you're in, it means something a little different. If you're basically a researcher, you're looking at how you can get corticospinal tract fibers to regenerate. If you're a neurosurgeon, you're trying to figure out ways to avoid injuring the tract during surgery. And if you're a neurologist or an electrophysiologist, it means something completely different. Next slide. And next. So we're going to talk about two syndromes. One's called Bell's-Cruciate paralysis, and the other is called acute traumatic central cord syndrome. And they have very similar appearance. They both present with severe weakness of the upper extremities, with relative retention of lower extremity function after cervical spinal cord injury. Next slide. And so how did these come about? Herbert Bell was a neurosurgeon in Cleveland back in the 70s. He's probably in his 80s now. And he described this syndrome where patients who had upper cervical cord injury would present with paralysis of the hands without weakness of the legs. Next slide. And so he developed this syndrome, and the way he explained it was that he felt like the corticospinal tract decussated at different levels for upper arm and lower leg fibers, so that somehow when you had an injury, you could injure the medially placed upper arm fibers and spare the leg fibers if there was just a precise lesion at the cervical medullary junction. Next slide. And then Wallenberg, you know, in the 1800s, described one case of a patient who had a stroke, who ended up with ipsi contra arm leg weakness, and he could only explain that by thinking that these arm and leg fibers decussated at a different level. So that's how the premise of that syndrome started. Next slide. And then there's acute traumatic central cord syndrome, which I'm sure all of the residents have seen before. We probably get an admission a week with these types of patients who are elderly, have pre-existing spinal stenosis, and have severe hand dysfunction without leg problems. Next slide. And this is a slide from Netter, just kind of showing the premise of it: stenosis, fall, hyperextension injury, and a central injury to the cord, picking off medial upper extremity fibers and leaving alone the lower extremity fibers as the basis for the syndrome. Next slide. And so Schneider was a neurosurgeon in Michigan. in the 60s and 70s, and he published like 4 or 5 seminal papers looking at pathology, presentation, and sort of came into being. And it really hasn't, the thoughts about it haven't changed much over time. Next slide. And so the reason why he felt like there was somatotopic localization to the corticospinal tract was studies by Forster in the 30s, who did electrophysiologic studies of the corticospinal tract and showed that there was a medial lateral gradient between arm fibers being medial and leg fibers being lateral. Next slide. And so just to go quickly over a typical case that we've seen recently is a 57-year-old unrestrained driver, came into the ER after being transferred from an outside hospital and had significant weakness and paresthesias in hands, but normal strength in his legs. Next slide. No really significant past history. Next slide. And you can see his exam here. His motor scores in his legs are normal and in his arms are way off, particularly distally, where he's essentially completely paralyzed in his hand intrinsics and finger flexors. Next slide. And so looking at the MRI scan, you can see as ventral cord compression and intrinsic cord changes seen centrally in the cord. And next slide. Next. And so this was his diagnosis. Next slide. We ended up doing surgery early on him. Next slide. And he really didn't have much improvement in motor functions immediately post surgery. He did have some paresthesia improvement, transferred to rehab post-op day 4, was in rehab for 4 weeks, and then seen, next slide, 2.5 months post-op. And he really had a lot of improvement in his hands at that 3-month post-op. Go to the slide before. He really had a lot of improvement and his gait was normal. And so that's kind of like a pretty typical sort of outcome for central cord injury patients that are on the more mild side. And we obviously see total variations on the theme. Next slide. So the real question is, is there laminar organization of the corticospinal tract as it is in the dorsal columns in the spinothalamic tract? And, what is the reason why patients present with greater hand weakness? Next slide. And so this to me is a very interesting slide because, I know Dr. Harrows always comments on this copy and paste type of situation in medicine. This is sort of how it's kind of played out in the textbook. So if you look at any textbook that is either for medical students like Gray's Anatomy or for neurosurgeons like Greenberg or for neurologists, which is the textbook on the right, and that's the neurology text that pretty well all neurologists residents look at. If you look at all 3 of these textbooks, they basically all say the same thing, that, the corticospinal tract is layered, leg, being lateral and arm being medial. And it all stems from that work by Forster back in the 1930s. And, we're in our 10th edition of Greenberg, our 40th edition of Gray's, and it's never really changed. So let's just see what evidence exists to sort of refute that concept. Next slide. So what are some of the neuroanatomical studies? Go ahead, next slide. So if you look at the corticospinal tract and just kind of follow it from proximal to distal, the motor fibers start in M1. There's 100% somatotopic representation there. That was work done by Penfield, many years ago. And sort of the leg fibers are medial, and then arm, and then face, tongue, trachea as you go to a laterally situated on the cortex. Then it goes down the posterior limb of the internal capsule, then into the middle of the cerebral peduncle of the midbrain. Then it goes through the pons. Then it goes to the medulla and into the medullary pyramids. Then it crosses. and then it goes into the cervical cord. And there's certainly somatic-topic localization proximally. The other point of this slide is that when you look at the corticospinal tract in humans, it is radically different than lower animals. Certainly if you compare it to the rat, the corticospinal tract is in the dorsal columns, and as well as it is in the opossum. But as you go up to cat, dog, monkey, and chimpanzee, you can see that the cortical spinal tract just explodes in axon number, complexity, the number of fibers that directly link to ventral motor neurons in the cervical cord. And that's totally consistent with the fact that, you know, as we became humans, we needed to develop thumb function, opposable thumbs, and it just sort of represents the fact that our hand function has gotten incredibly complex as you move up the phylogenetic scale. Next slide. So that's sort of a summary of what I just said. CST in humans becomes way more complex, bigger, and more important for hand function. Next slide. So what about tracing studies? Next slide. There's been a number of tracing studies, including Markey degeneration studies, as well as anterograde tracing studies in the cortex that basically shows what this slide shows is that if, A, B, and C is face, hand, and leg injections, and that when you look at the midbrain, there is laminar or somatotopic localization of fibers, but by the time you get to the medullary pyramids, which is the middle row, there clearly is no somatotopic localization. And then the cervical cord, which is the fourth row down, doesn't show any distribution of hand leg fibers. Next slide. And this is modern day tracing studies in the chimpanzee showing exactly the same thing. If you do an injection in the leg area versus the hand area, and you look at the medullary pyramids in B, there's no difference in the fiber distribution. So basically all the fibers get mixed up as they go down into the cervical cord. Next slide. So really that whole concept of a localized injury to the medial part of the corticospinal tract doesn't make sense. And it also shouldn't make sense to you in the sense that, it's very hard to get a pinpoint sub-millimeter injury to a tract from such, diffuse cervical trauma. Next slide. So, and then, you can actually cut the corticospinal tract in monkeys, either unilateral or bilateral, and that's been done by Lawrence and Cooper's, many others. And the interesting thing is that you can completely section the corticospinal tract in a monkey unilaterally, and you would hardly know that you actually injured anything. The only thing that you can tell is that there's some subtle hand dysfunction after surgery. Now, next slide, if you do bilateral lesions, it's a little bit more obvious, but even then, their leg function is incredible, and all of them show significant recovery over time. Next slide. And so what about neuropathology? That should sort of end the argument as to whether there's any medial lateral spread. And so this is a paper from the Miami project now almost 30 years ago, showing that in a lot of patients with central cord injury, you sort of see a diffuse injury to the corticospinal tract, not a medial lateral gradient. So that was the basis of something I had written 25, 30 years ago. And the question is there any new data to kind of support that? And certainly imaging has gotten a lot better over time, and we should be able to figure this out with modern day imaging studies. Next slide. And so next slide. There's definitely a bunch of papers now showing tractography in humans, showing that there is somatotopic organization to the motor cortex, certainly in the posterior limb of the internal capsule, which is B, and C, and actually corona radiata. You can see that there's distinct fiber tracts, but as you get into the posterior limb of the internal capsule and pons, it's definitely starts to mix up, very consistent with the prior tract tracing studies. It's a little harder to do tractography in the cord, but certainly in the brain and in the brain stem, that's what it's showing. Next slide. And so this is a project that Aditya did when he was here, looking at a bunch of patients with central cord injuries, and then looking at the white matter injury in the corticospinal tract to see if there was any medial lateral variability, so to speak, consistent with prior theories of somatotopic organization, and essentially looked at 11 subjects and compared white matter injury between medial and lateral, and as expected, found no difference. Again, suggesting it's a diffuse injury to the cord, to the corticospinal tract. Next slide. So, again, this is the slide that I showed you at the beginning, so, from the 3 textbooks, Gray's Anatomy and Greenberg and the big neurology text. And so with the help of Roberto, we submitted an article, next slide, kind of updating how we sort of should think of how things look. So you can see proximally, you do have a motor homunculus. That's not different. The localization in the cortex, the corona radiata, midbrain, posterior limb internal capsule, all the same as what textbooks say, but certainly by the time you get to the pons medulla, fibers start mixing. We now have like 6 or 7 pieces of evidence of that. And then, as you know, corticospinal tract has crossed and uncrossed fibers. And certainly for the crossed fibers, by the time it gets to the cervical cord, all of the hand, arm, leg is sort of mixed up. And so that's the way it works in the CST. Next slide. And then the explanation, for the upper extremity fiber weakness, like we showed in that case, really relates to the fact that it's a diffuse injury to the corticospinal tract, and that is the substrate. It's so important for hand function that's why you see the prominent hand dysfunction in those cases. So next slide. So, and the next one. So that's all I had about corticospinal tract. Hopefully, Ignacio, you got the other talk that you can hopefully put up. And while he's doing that, I will entertain any questions anybody might have. So the next talk, again, it's about 20 minutes or so, is really targeted to sort of more of the junior and mid-level faculty, but really anybody who's interested in academic medicine. And this talk could be given to neurosurgeons, or it could be given to entomologists or lawyers. It really is kind of the same process. And I got to say, when I was a resident, and certainly when I started, I had no clue what the whole process for academic promotion involved. And I think I know a little more, but I'm always learning. And basically having gone through the process, but also sitting on a number of different university committees, including the Academic Promotion Board, which I'll talk about in a little bit, is you definitely get a sense of what the process is. So that's basically what I was going to talk about. Next slide. So the next slide, basically disclosures. Next slide. And just I think one of the important things to know is that as you enter a faculty position, kind of what you did before, I wouldn't say is meaningless, but it doesn't go into the equation of promotion. So like for me, my personal story, probably going to the worst medical school in a foreign country, and probably literally the last person in the class got my acceptance letter in like early September. It doesn't really matter. So if you graduate from the Harvard of the South, or the real Harvard, it really doesn't play a part in your faculty promotion process. Next slide. So what really does matter, and it is very confusing, go ahead, next slide, is this this next picture here, which is essentially the 4 pillars or 4 legs of promotion, which includes, you know, clinical endpoints, research endpoints, teaching endpoints, and administration, which includes community service. And there's certainly a process through instructor, assistant, associate, full professor, and then there's this concept of tenure versus non-tenure, and I'll talk a little bit about that. The other part of it is not only the 4 pillars, but the time part of it. So like, you know, there is a certain time commitment to each of these phases that have to be done, and it can vary from one individual to another, from as little as 2 to 3 years to as much as 20 years in each of those roles. Next slide. And so the next slide basically says, oh, back. So thank you, Ignacio. Let's go back. So, and the next slide just basically says that, you know, again, what you did as a medical student, residency fellow, is really less important than what you actually do once you're on the ground. And that's when the clock starts. Next slide. So what about the process? And the process is really very arduous and takes a while. And so that's kind of what this shows, is this, you know, it's a number of different hurdles. And as you go through it, you can see there's layer upon layer upon layer that you have to go through. And each one, you know, takes time and effort for sure. And I'm going to go through many of these, but just to show you what are all the processes: getting an updated CV, talking with your chair, developing a personal statement, letters of reference. So next slide. Letters of reference are really difficult in neurosurgery because we're such a small field. Everybody knows everybody. And particularly if you're in a subspecialty, it's, I would say, sometimes almost impossible to find someone who can write you a letter of reference that is certainly not that is not arm's length. And so that's one of the biggest struggles that we have. You know, for example, I don't know, you're a peripheral nerve surgeon. I mean, there's only maybe 70 people who are really in that area. And if you're, you know, publish a lot, you probably have published with everybody, especially if you've done guidelines or those kind of things. So it's hard. Part of my job is to make the medical school understand that, you know, sometimes you cannot get someone who doesn't know you at all fill out a letter of reference. And not only do you need one of them, but you need 8 of them. And that's an incredibly hard task. Next slide. And then you have to develop a personal statement, which is pretty self-evident. Next slide. And so what about the clinical piece of everything? Next slide. So the clinical piece is, you know, excellence, high volume, subspecialization, stay current, and certainly publish. Next slide. So this kind of shows the fact that things are so rapidly changing. I mean, like, this was me as a resident in 1987. There was no cell phones. There was no internet. Published my first paper on a Mac computer. That was my car. You needed a separate instrument for taking pictures. And now in 2021, it's totally changed. And I'm sure in 2051, this will look completely different. Next slide. In spine surgery is similarly, I mean, this is kind of what was the state of the art in 1989 in spine surgery. We're just starting to put pedicle screws in. Cervical plates had to be bicortical. They're very challenging to get fusions or unbroken screws. And certainly you move the pendulum 30 years and you know, what spine surgery is now is 100% different. And pretty well nothing that I did as a resident, I do now as an attending. And so that's important to definitely stay recent, if you will. Next slide. And the other thing is obviously to publish. So I'm going to ask Greg, this question is, if a tree falls in the forest and no one is around to hear it, does it really make a sound?
Are, are we saying that if we publish and it's not on PubMed, does it matter?
No, I was asking you this philosophical question. People have written books about it. So does it really make a sound if a tree falls in the forest?
Yeah, I mean, it makes a sound, but nobody's there to witness it.
Yeah, so you actually pulled the analogy off right from the start. I wanted to torture a little bit, but yeah, I mean, if you, and I've seen that countless times, is that people will come up with these great findings or, develop a phenomenal procedure, but if you don't publish it, it really just stays in your own brain and it never moves forward. So publishing is super important in that clinical aspect of things. And next slide. And so the university has tried to develop more rigorous ways of figuring out what is the value of a publication, and it involves which authorship you are. First or senior is obviously the most critical, and the middle authors are less impactful. And of course, the impact factor of the journal is super important. And peer-reviewed articles are much more important than textbook chapters and invited commentaries, obviously. In neurosurgery, again, we have a big challenge because we're such a small specialty. Our leading journal impact factor is only 5. While if you go to neurology, which has so many more neurologists, it's hard to find a publication that's less than 5. And it has a lot to do with, your readership and some of the challenges that we have of being such a small specialty. Next slide. So what about research? That's obviously a big component. And research could be clinical research. It could be basic science research. Next slide. Or it could be translational research. I mean, it doesn't have to be one versus the other. The only thing I would say about research is, obviously, move to excellence. Try to pick an area if you're a basic science researcher in neurosurgery that is unique and human, because you're competing against PhDs and they do this full time and they will run over you if you don't have an area where you can sort of niche and work around that, so to speak. And because we interact with human patients all the time, that's obviously an area where many clinical basic sciences scientists work in. And it's good if you can make your clinical interest and your research interests align. I mean, if you're a brain tumor surgeon, it probably doesn't make a lot of sense to do research in, peripheral nerve regeneration. It'd make a lot more sense to do research in brain tumor research. And then, of course, publish and get grants. Next slide. And so next slide. And next slide. And so this is, again, sort of a more rigorous way that the university is trying to score research grants. And you can see it's pretty self-evident. Federal grants are more important than state grants, are more important than foundation grants, et cetera. And they put a number on that. Next slide. And so what about teaching? I mean, teaching, we all teach residents. Some people have teaching portfolios, next slide, where they're more involved in teaching medical students or undergraduate students. And it's possible to get promoted just based on a teaching portfolio. But the evidence that you are an excellent teacher is, has to be submitted based on scores from your prior pupils, et cetera. But we definitely see that. The last leg is administration and community service, kind of linked. And that could be committee work, either departmental at a hospital level, at a university level, or community service, whether it's donating your time towards, Haiti or a bunch of other opportunities for community service, whether it's local or international. Next slide. And of course, time. And this is showing that there is certainly multiple layers of oversight going from your faculty as well. That's something we didn't talk about, but certainly there's a faculty vote, and the people who are voting for you are usually one strata above. So associates vote for associates, and full vote for assistants, and fulls a vote for associates, etc. So again, staying in tune with your colleagues and letting them know what you're doing is an important part of the process. The dean reviews it, the provost reviews it, and in tenure track situations, it needs approval from the board of trustees. Next slide. And so there is this concept, it's not a concept, there is this track of tenure track, which basically, if you can get tenure, it means that you have some protection in your job with respect to being fired, is kind of what I would say. It's really more relevant in the basic sciences, and it is, for in the clinical tract, it usually involves getting federally funded research, but not always. But that's usually the things that will put you over into a tenure track position. There's really two ways to do it. You can go on a tenure track when you start, and so you say, I'm an assistant professor on the tenure track, and it implies that you will get tenure. It used to be 7, now it's 8 years, that you will get tenure within 8 years. And the problem with that track, and I remember Dr. Green talking to me about this 25 years ago, is that if you do that track and you are unsuccessful, you basically are fired. And even if you've done great things along the way, but didn't make that strata, you're fired. And so it doesn't make a lot of sense. It's a lot of risk without reward potentially at the end. So what we suggest that most people do, if they're interested in that track, is to start in the normal track, and then you can always request a track change somewhere along the line, so that you can you do that track change when you're pretty convinced that you will actually get it. So that way you make it like a no risk type of situation. Next slide. So we talked about track changes. What are some of the things that would consider early consideration for promotion or tenure? Clinical productivity and administration. I think we talked about most of these things. And the last thing, as I finish off a little bit early and open it for any questions, is this whole thing about citizenship. I've seen it, unfortunately, where people have done absolutely all the right things, published, great research, great clinical work, but they have gotten in trouble with regards to being a bad citizen. Like, I don't know, I give you, I could give you countless examples, but it's just like where there's been bad interactions, and it's sort of gotten up above the department level and has gotten to the dean and this and that. And so that is sort of in that part as well, is that usually good citizenship, it means not getting in trouble for any of those things. Certainly learner abuse, which we all sign letters for, certainly when we start, would fall into that category of not good citizenship. Next slide. Next slide. I think, yeah, obviously these were just slides to show you that there's just, it's tough. I mean, there's no doubt that it's tough. We have a lot of things that make it more difficult now than it was before. We have things that make it easier. Certainly the publication, process is a lot easier now than it was 30 years ago. But there's a lot of other things that sort of creep into our daily work that make it more difficult. Next slide. And I think that's just sort of a summary of all of the things we talked about: trajectory, tracks, teaching excellence, reputation, service, citizenship. And next slide. And there, I'm done. I apologize again. That's my fault that I didn't get the Zoom right for whatever reason. And I thank Ignacio for accepting my emails and being the button pusher. I just want to make sure that there isn't any questions about either of those two talks. All right. I see Ashish on the line. Hope everything is good on DC. And if there isn't any questions, I'll hand the mic over to Bobby.
Those were great talks, and certainly the second part is super helpful for anyone that's navigating through those promotion processes. Well, thanks so much for giving me the opportunity to talk today. And I was talking with some of the residents, and they thought, talking about NIH funding and grants might be helpful. So, this talk that I was asked to talk about is my path to R01, but really it's a long history of failures. I think we often see the celebrations that people have and all this, nonsense on social media is really characteristic of that people don't commonly post their failures. So it looks like everything is success, but that's really not the case. So I thought I would go through some of this, and hopefully that'll be helpful for some of the other students and residents, or or faculty that are going through similar processes with grants and things like that. This is my funding and disclosure slides, and it'll be pretty important for this talk, because a lot of this funding, both with consulting but also these smaller grants, is really what led to getting larger grants. So it's hard to get some of these larger grants without having enough preliminary research, which usually requires some level of funding below or smaller grants. So we were lucky yesterday, we were awarded another BAF grant, which is a Brain Aneurysm Foundation grant. And the reality is, I think that's our second BAF grant, but we've also probably had maybe 7 or 8 or 9 rejections, on the way to even one of these pretty smaller grants. So, originally that started with me applying to quite a few grants, but for NIH type funding, I applied for a K-12 grant, didn't get that. Went the next year, applied for a K-12 grant again, went to the K-12 meeting, didn't get that. Applied for a K-08, didn't get that. Applied for an R01, didn't get that. So it's a lot of these kind of negatives, before anyone has a positive. So you just have to have, I think the biggest thing is having a thick skin for all these failures. So I think when you're thinking about if you want to go into a research track, especially if there's a basic science component, a lot of that's going to start in your training, and you can always go back and get more training. I certainly have heard of people that went on to get R01 funding that went back and did a lot of training during their job, and even got grants to go back and do training in their job even 10 or 20 years later. So I think you can always alter your trajectory, but the farther along you go, obviously the more difficult it gets. So for me, I ended up I thought I was going to major in anthropology, in molecular biology in college, but I ended up majoring in anthropology, maybe because I wanted to do too many other fun things and not fool around in the lab. And it wasn't really till medical school that I started circling back and becoming interested in research. So when I was in my third year of medical school, I took 2 years off and I did the NIH Clinical Research Training Program. And while I was doing that, I started getting background in cerebrovascular basic science laboratory skills while working at Columbia University as a research fellow. And at that point, I was really doing basic science, translational, and clinical research. And it was mainly the research that I thought was going to be relevant to my future in clinical practice that really sparked my interest in going back and doing a lot more research. So then I went to neurosurgery residency at University of Virginia, and that was a real challenge to try and fit research into this. So I did endovascular fellowship at Thomas Jefferson, and then again at University of Virginia. And during that time, I had a small lab space. I started collaborating with people. I had a number of mentors, and so I was really working on developing further basic science research with the hopes of submitting grants down the road. So I think for the residents, if you want to have a basic science track and side, that's really something you've got to figure out how you're going to do your training, but also continue to push along so that you don't have a 7-year gap without any real progression of basic science research. Then I did another fellowship, and then I came to University of Miami. So I think the thing about writing grants and working on all these things is it's shockingly painful. And we've all written, essays in high school, college. We've written many things in medical school, and then most of us have written research papers, but that is completely different than research grants. It's an entirely different skill. And, when I started writing grants, I thought, well, I've done lots of writing, this is pretty straightforward. I can just do this. And, there's really, my mom always worried me about free candy, but I really think that there's no free candy in writing these grants. And it's not like being on a date, it doesn't just flow perfectly and smoothly. It doesn't look like this. A lot of times these grant processes look and feel, more like this, more like the things that we see in clinical practice, like someone's stabbed a wrench through your forehead. So I think that grants, it's really not like the SAT, the MCAT, the shelf exams, your steps, written boards. It's really different from writing a manuscript, and it really needs practice. And a lot of us are not used to failure. When I talk to, I look at a lot of the residents and applicants and medical students coming through, their CVs are unbelievable. These are people that are in the top, 0.1% throughout their life, and they're just not used to rejection and failure. And I think the NIH builds a certain level of failure into all this because they don't want people to receive funding and then not carry through with the projects. So they want to see some level of thick skin, as you go through this process. I think a lot of people write grants and then they fail once or twice or 3 times and then they give up. And I think that was something that I really saw at the K-12 meeting where, you would kind of talk to your peers and they would talk about how difficult a time they were having with getting funding and, why am I doing this, and sort of give up. And certainly I probably had that talk with myself internally, maybe a couple hundred times. And that talk with sort of peers and friends and family, probably a couple hundred times as well. Because one of the things that's really difficult about these grants is there's no gold star. There's nothing at the end, especially if you fail, to put on your CV. So it's not like writing a paper where, it might get rejected a couple times or many times, but eventually it gets published and you have something to put on your CV. The grants, they get rejected and you might think, wow, I just spent a month or 6 months or a couple of years writing this grant, and then sorry, that was a transfer. So you might spend a couple of years writing a grant and it keeps getting rejected and rejected and rejected. And you're like, wow, I'm just spending all my time poured into this and to these experiments that don't seem to be going anywhere. And I don't have something to put on my CV. And I think that goes greatly into Dr. Levy's talk, that you have to have varying levels of risk. So, you know, same with publications, you have your case report, your case series, your retrospective review, your prospective review, and then you have your prospective science studies, which might take, you know, years and hopefully pay off with major publications. So that's my son. We always talk about in our family, there's not really participation trophies, these trophies that they give out. This was my son's trophy just for playing soccer and being on the team. So, you know, going back to the dating analogy, this is much more what that grant process looks like, or maybe when I used to go on dates, what that kind of looked like. And if you have a kid, you know, you've seen this movie probably, I don't know, 10, 20 times, which I have. And I think every time you kind of fail on one of these grants, you got to sort of internalize that, take the positives from that and move on. And so, you know, this is, I feel like, usually when I get some sort of grant back that's been rejected, this is, you know, usually how I feel. And I think the process needs to be, how are you revise your science and your experiments and your grants? So eventually, you know, we all want to get to something that looks like this. So this was another thing that Dr. Levy talked about, which was really putting your clinical practice together with your, sorry, give me 1/2 second. So mirroring your clinical practice together with your research practice. So for me, I was really interested in cerebrovascular disease and mainly aneurysms. So this, you know, we're all familiar with these pictures. This one, this is a subarachnoid hemorrhage on the left from a ruptured aneurysm. This next one is primarily intracerebral hemorrhage with a little subarachnoid hemorrhage. Aneurysms can also present with subdural hemorrhage. And then as well, they can present looking like tumors. So these were all aneurysms. And this is, you know, one of the main things that really captivated my research interest and also my clinical interest. So for whatever reason, aneurysms can grow to be sort of these giant size. This is, you know, a partial wall of my slides of giant herniating aneurysms, but they can also rupture at a really small side. And the reality of that is we really don't understand a lot of the pathogenesis behind why cerebral aneurysms form, what makes them progress, and then also what makes them rupture, and then why some aneurysms remain quiescent and some aneurysms are unstable and bleed at sort of a small side or a larger side. So in planning out all this basic science, you know, this basic science, this trajectory, your research, one of the things that's, you know, not talked about enough is your mentors and the people that kind of guide you along the way. Everybody thinks, well, you know, somebody has kind of gone through this path and done a lot of this on their own. And the reality is, you know, at least for me, there's an army of people that are around me that help me on almost a daily basis. And this goes into planning experiments, planning grants, you know, all the way down the line. And you're going to have numerous failures, and you have to assemble a large number of teams and mentors along the way to help you. And, you know, this started going all the way back to medical school, residency, moving forward to taking my first job. And even taking the job at Miami was somewhat planned out to have mentors around me. So, you know, I can't thank these people enough, but really, you know, this slide is even way larger than this. If I was going to talk about all my mentors individually and what elements they brought to the table, that could be a whole series of talks that would, you know, probably put everyone to sleep. But at University of Virginia, Dr. Owen's a smooth muscle cell biologist, and I had a little lab space within or sort of next to his lab, and he was sort of my primary mentor, and I went to all of his lab meetings, and I tried to go even when I was not on sort of research time, whenever I could basically make his meetings either one-on-one or in the lab as a whole. That's what I did. And when I moved to University of Miami, I did the same thing with Dr. Hare, trying to go to all of his research meetings and meet with him regularly, and picking up other collaborators like Dr. Tobarek, Dr. Sanjoy, and continually going to other locations to gain more skills that I didn't have at the time. So visiting Dr. Hassan in Iowa, Dr. Hashimoto, Dr. Kalmas, et cetera, et cetera. But going back to my residency, there are really a number of really key members that I had that were integral mentors to kind of this process for me. And, it was meeting with Dr. Oldfield regularly to go over science, and meeting with Dr. Cassell to sort of go over life, life goals and trajectory and planning. And Dr. Jane pretty much almost on a daily basis, or certainly an every other day basis. But each of these people brought different things to the table. And for Dr. Cassell, it was really about relevance. And this was, something that he coined, way before Jerry Maguire, which I think we're all familiar with. So I think most of us are familiar with that scene, and it's really about, how can you have a couple dollars, for some limited experiments and turn it into something that's more sustaining. And the first element of that, really, this was a Dr. Oldfield slide or element, which was you have to have good science. And that takes a lot of, hard work, failure, but also modeling around other people that have been successful in their experiments, things like that. And it was, very common that I would give a talk at Grand Rounds at University of Virginia as a resident. And Dr. Oldfield would kind of listen to the whole thing at the end. He didn't have sort of positive questions. They were just like, man, you just feel like he cut you in half. They were sort of like, got to the really nitty gritty of experiments, picking up potential errors, issues, flaws, and sort of picking you apart. And it wasn't, he meant it as a positive to sort of help push everything along. And he would do that on a personal level as well, sort of when you weren't at Grand Rounds. But it was very analytical, and it was very helpful, but it was also very hard to sort of take that level of criticism. So I think the first step is really having good science. And when Dr. Korn from the NIH, when he came here to give his talk, if any of you caught that, or if you go to the meetings, I've heard him talk probably about 10 to 15 times at this point. And he always has a slide, something like this about good science. And that's something that needs to be developed with your mentors, so that you're not, going down a rabbit hole that takes you down, something could take you down years in the wrong trajectory based on some small flaws, either in your thinking or experiments. The second thing that Dr. Levy, talked about was publications. You need to have a series of regular publications without, major gaps in this. And it also needs to have some impact publications. So, I guess I get a lot of flack for having a lot of publications, and I published a lot as a medical student resident, I guess as an attending, but that was mainly by surrounding myself with great people. But although you might have a lot of publications, you do have to have some impact publications as well. And this publication on the right on cigarette smoke probably took me about 7 years. That was experimental work over a really long time, and that really paved the way for a lot of this funding, or some select publications really paved the way for my research. And you have to have varying levels of these publications, and that can be varying levels of impact, but a lot of them have to be relevant to your field. So coming back to my sort of clinical interests and and elements. And again, coming back to Dr. Cassell, his main point that he kept hammering home into my brain was that it's got to have clinical relevance. So for me, these were the things that I was seeing on a regular basis and continue to see. You know, this was a patient on the left with a giant aneurysm that we did a bypass and reconstructed the carotid. And these were the things that I really loved. But man, if my brain looked like this at the end of the surgery, even though this patient had a good clinical outcome, I would be very disappointed. The person on the right is this person that was coiled, I don't know, 6 times in another hospital and then presented with a second subarachnoid hemorrhage. And, we see these things, and I just thought, we've got to do better as we go forward. And looking at, again, that great slide that Dr. Levy put up from 1987, or was it like 1927 when he did his residency and training versus, his practice now, moving from, the old Mac giant computer and pagers all the way to Tesla. If we're doing the same things we are now in vascular in another 5, 10, 20, 30, 50 years, I think we've done a major disservice to our patients. So for my research, one element was thinking about a medical therapy for aneurysms. Right now, there are no medical therapies for aneurysms. So that's one of the major things that I focused on. So clinical relevance for my research was really focused on a couple different areas. So medical therapy, imaging, so coming up with new or better imaging modalities, those that could pick up aneurysms and identify unstable aneurysms, and then treatment options. So coming up with better treatment options, whether that's a medication or an endovascular option or new stents or coils or things like that. So we've got to be looking, beyond what we're doing now to develop the next best things. So a medical therapy, and these were really out of the types of things that Dr. Cassell would say on a regular basis. When the NIH is looking at grants and funding, they want to see an unmet clinical need. So a medical therapy for aneurysms could certainly satisfy this. Currently, the options for aneurysms are observation with serial imaging, microsurgical treatment, or endovascular treatment. So it's not like a lot of these other areas where we can just put somebody on a pill. So potentially you have somebody that has a giant aneurysm of the basilar tip. They're 75 years old. They have a high chance of rupture, but they also have a high chance of morbidity and mortality with treatment. And so a medical therapy might inhibit aneurysm progression and rupture and satisfy a great clinical need. A medical therapy for aneurysms could be better than existing therapies. So, again, we still have major problems with clipping and coiling, both from a morbidity and mortality standpoint. And then more so for endovascular, a major problems with recurrence of aneurysms after they've been treated. So maybe a medical therapy could be on coils or stents, or it could be given along with endovascular therapy to decrease the chances of progression or rupture after treatment. It could be readily available. So this is a major problem with a lot of these, clipping and coiling, is it requires a lot of technology, infrastructure, and support. So that's not something that's available in many countries still. And it's something that, we really take for granted. But on top of that, maybe it's something that's delivered, my phone is going off right now with a physician at another hospital wants to transfer a patient. So maybe that's a medical therapy that could give, while we're waiting or working out transferring patients. And in this sort of modern network, our transfers might come from literally, this one's from Kendall Hospital around the corner, but they also come from, we had one from the Caribbean the other night, and last week from Mexico. So medical therapy could really be beneficial for a lot of these patients, and is certainly in a lot of other countries like Europe, these longer distance transfers are really common. It could also be cost effective. So these endovascular technologies, and certainly clipping and taking a patient to the operating room, are really expensive, and they're not really for a lot of third world countries, especially, it's not a very reasonable option. So medical therapy could be really a cost-effective, excellent option for some patients. And these are the types of things, regardless if we're talking about aneurysms or spine or tumor or whatever that you're going into, these are the things that you want to think about when you're putting together NIH proposals, because these are some of the major things that they're thinking about when they talk about relevance of your grant and impact. So for cerebral aneurysms, I think our current knowledge of the biology is inadequate, and a better understanding of the basic biology is necessary, as it may help drive patient selection, development of non-invasive therapies, and outcomes. So my research really started with human blood and tissue, and this is another thing that Dr. Oldfield and Dr. Owens talked about on a regular basis, and that is relevance in how you start and plan your experiments. So a lot of this came from humans, and then I worked backwards to animals and cells. A long time ago, most people started with cells, then they moved to animal models, and then they moved to human models. Why? Because it's easier, more available, and science didn't have access to human tissue, blood, things like that. And the problem is, things that were all often amazing discoveries in, zebrafish and published in Nature had no relevance whatsoever to humans. So this is a problem with the models. And that's a common critique you get on your NIH grants is, well, this is great. These proposals for the experiment sounds amazing, but what is the relevance for humans? And do these models have any impact on how we're going to treat patients? And often, unfortunately, the answer is no. I mean, the system in mice is often very different from the system in humans. So for me, the research, I tried to always start with the human side and move back. So for humans, that started looking at molecular alterations in blood within aneurysms and tissue within aneurysms, developing microRNA analysis, then PCR, then immunohistochemistry. And then moving backwards to aneurysm models in mice, rats, rabbits, canines. I mean, we made aneurysms in just about everything. And really looking at how endothelial cells were altered in human tissue, then looking back and see, well, was it the same in animal models? And then what was the problems in aneurysms? So looking at the normal endothelial cells, but then also endothelial cells in aneurysm models, and looking at why endothelial cells changed their function and entered into an inflammatory pathway, and then why they died, and how this really had an impact on aneurysms. So it's really this process that endothelial cells contribute to aneurysms has to do with a number of molecular pathways, but this is the main one that I focused on for the R01 grant. We're looking at many other things to develop and look at other pathways and see how it interacts with this. But at least for the R01, I was mainly looking at endothelial cells. It's important to know that this is a very small path or part way in overall aneurysm formation and progression. And some of my other grants and things have mainly looked at smooth muscle cells. So for me, endothelial cells were incredibly interesting, and probably because I'm generally a big nerd, but these are two endothelial cells that are sticking together, but in aneurysms they're a lot of times they're falling apart and they're not sticking together, so they're developing an altered environment that contributes to aneurysms. So under the normal state, you have your differentiated endothelial cell, which is mainly responsible as a barrier, regulation of blood flow, pressure, immunoprotection, and it has increased endothelial cell marker genes. Then something happens and you get phenotypically modulated endothelial cells that are important in migration, proliferation, matrix remodeling, and there's decreased endothelial marker cells. So again, looking at this a little further, and this is what we study, in the lab as well, is that after you have your normal state with elevated endothelial marker genes, there's environmental factors, hemodynamic factors, oxidative stress. This leads to phenotypically modulated endothelial cells with increased inflammation, matrix remodeling, decreased endothelial marker genes. There's further events like environmental hemodynamic stress, oxidative stress, which eventually leads to death of endothelial cells and apoptosis. And this is somewhat's going on in normal blood cells as you have aneurysm formation and then rupture. So we looked, for this grant, it's mainly looking at this pathway, and the aims are divided into these different elements to look at these pathways. So aim 1 is primarily in mouse models and also cellular cultures. Aim 2 looks at rabbit models, which uses special stents to further look at this pathway. And then aim 3 looks further at blood and tissue, and then looking forward to human clinical studies. The aims don't necessarily go in order or have to go in order. They started with humans and then went to animals, then cells, then rabbits, and then back to clinical trials in humans. So in developing this grant, we go back to, again, the funding. This is the important stuff, which is, how do I kind of get these experiments off the ground? And during a resident, I got some small level grants. I got some funding through my residency and things like that. And then through faculty, I was able to push these experiments forward. By one, I got some money. I was very lucky to have some money from Dr. Levy, Dr. Marcos, and the rest of the department. And I basically applied for every grant that I could. And I had repeated failures, but I got a Brain Aneurysm Foundation grant. I had an NREF grant. I got a Joe Negro Foundation grant, a B Foundation grant. And a lot of these are pretty small grants, but they allowed me to keep pushing experiments forward. I got an NHULTR grant. While I was doing this, I was working on patients and philanthropy. Any patients that I saw, I tried to circle back about our research. Certainly don't have any of the skills that Dr. Green and Dr. Levy have, but that's another thing that you need to develop that skill, or certainly I do. But that can be another critical element of funding. One patient can be enough to run your lab for many years, whereas most NIH funding will only last you for 1 to a couple of years. I also collaborated with a lot of companies and do a lot of consulting and funnel that money back to the lab. And so we'll talk about that a little bit more. So these first 4 grants really provided the framework to start a lot of these experiments, push these things along. And then while I was doing that, I also worked with a lot of companies, and I would test things in the lab. So that money where I tested a new device, that would go back to the lab. I did a lot of consulting, and I basically donated that money back to the lab to help push forward further experiments whenever I could. And so I also learned a lot from this consulting and from collaborating on research, which was in my field, but not necessarily directly relevant for my grants. So this was some of the studies that we did for Medtronic. I actually think I placed, 180 stents into rabbit models when we were working on Shield and Vantage. These were the next generation stents that came after the pipeline embolization stents. So this was looking at occlusion, but also basic elements like endothelialization, inflammation, thromboembolic problems, how sticky the stent surface was, things like that. And what you realize is, Medtronic is a $100 billion company, and they have a lot of things that they can do very fast that will take you years. And so learning about how they've done things, how they failed, how they've progressed, how they evaluate these things was very important for my research as well. So this collaboration and that I had with other companies really helped my research, because a lot of these things, I wouldn't have been able to start had I not learned from their failures, other experimental failures. And then also they may have machines or hire off-site companies to use their machines when it's too expensive or not reasonable for them. For example, some of these we made aneurysms in our lab or other labs where it was easier. Sometimes we did the histology off-site, and that was something that I learned from my own research as well. I was trying to do all the histology all these things myself. Sometimes it's better to collaborate with an expert and send this to, your friend in Boston or in Minnesota or somewhere else where they can help you with some elements of this. So a lot of it is working on better collaborations to develop these skills. And I started learning that in the lab, with Dr. Owens, but also through these companies that really have money on a whole nother scale. So these were just some of the other studies that we did with those companies. And some of that funding from consulting helped me funnel back to my research. Then I got a CTSI NIH grant. That was, again, really helpful to push my experiments along. Also to collaborate with a lot of other people that weren't in the field that I was in, but they were building their research path, learning how they were doing things, learning how they were getting their studies off the ground. So that was really helpful to go to these meetings. This infrastructure of the CTSI is really built to get a pilot grant to help you move on to other funding. And you can get those CTSI grants either as a resident or as I think even as a medical student or as a junior faculty member. And this can really help put you around other faculty members with a lot of experience that can help build your research. So that was really helpful to push forward and see how I was going to get these research experiments done, specifically here at University of Miami, how other people were successful. Grant writing review workshops, super painful. People talk about going to these meetings and going to going to dinner, going to the beach, going to doing a lot of fun things offsite at the meeting. And I went to basically every grant writing workshop at every meeting that I went to. So I used to go as a resident. I went to ANS, CNS pretty much twice a year. And so that meant going to these workshops over and over and over again, learning, refining my grants. I went to the K-12 meeting, which is specific for neurosurgeons. You have to be starting your first job. So I would say, everybody should look into that. But that's a NIH grant specifically for early, first or second year neurosurgeons, and it's NIH funding. So that's another thing to look into. But I went to those meetings. They were usually in the winter in Boston, which I had very little interest in going to. Spending 3 or 4 days going through all these grants is really painful. And I got rejected twice from the K-12 grants. Then going to other meetings, I presented my K-08 rejections at meetings and had, that's super painful, having people sort of pick apart your grants while I was working on my K-08 grant. And a lot of these meetings, you present your grants and people tell you why it's no good. Then there was the NIH Nrcdp Emerging Investigator Program. So I did that as well. So that was a whole nother set of meetings that's designed for early, junior investigators trying to develop their grants. And so, it seemed like certainly I was doing something daily, weekly, monthly to work on these things. So, the NIH Emerging Investigator Program is another great one. It's through ANS and CNS, and it meets 4 times a year. That's another great thing to look into. The University of Miami has a grant writing class. So this was every Tuesday. I tried to go to this 2 to 6 p.m. working on your grants. And this was incredibly important for me. And they have specific classes for K-08, R01, R21. And I think a lot of people think, well, I'm just going to write the grant, look at some other people's grants and be successful. But unfortunately, that's not how it works. It takes a lot of pain. And these grant writing classes, this is the first page of my R01, which was similar to a lot of the other grants. And it took years of refining. And it wasn't, I just wasn't looking a lot of the times at the individual words. In the grant writing class, they look at every word on this page. Most reviewers read this page and they know right away, am I going to read the rest of this grant or am I going to throw it in the garbage? So if it doesn't follow the usual pathway that they're used to seeing and pull them into the grant, just like the first page you read of a novel, they're just going to throw in the garbage and they're not going to read the rest of the grant. So the grant writing class really taught me to, we basically put every sentence on a slide. Sorry. Every sentence onto a slide, working on every single word and coming up with, are these words important? Does this push the grant forward? So K08, this was sort of the next thing that I applied for after I failed at K12s. The K08 grant is 1/3 institution and mentor. So you got to pick your mentors, obviously your institution well. 1/3 individual career plan, how you're going to develop this career plan, and also progress as a scientist. And then 1/3 is the grant or your research. So that was another thing the reason that I had quite a few failures on was that the K08, it's not just about the grant, meaning your science. 2/3 of it is about your mentors, the institution, and then also your career plan and your development. And my K08s were getting absolutely ravished on this middle one, this career plan and the individual. And we'll come back to that. But my scores for institution and mentors were perfect. But these other things, I basically got annihilated on. So for K08, you have to have 50% protected research time. You've got to have the institution, the infrastructure, the mentors. And some of this also is clinical partners. So who are the people around that are going to help you? If you do vascular and you don't have any of your partners, the NIH knows that you're going to be on Q1 call and they're not going to award you a K08. So for me, my first mentor was really Dr. Owens. He mentored a lot of people to go on to get K08s. And then I had all these other mentors down here at the bottom that helped me in my training and progression. And then when I was looking at jobs and I decided to take a job at University of Miami, part of that was the thought that Dr. Hare was going to be my mentor for my K08. And that was even before I accepted the job. Dr. Levy and people set up interviews with people that might be beneficial. And I talked to other scientists at the university to see who might be able to help me with the K08. Dr. Hiros was incredibly helpful. And then also meeting with a lot of other scientists at University of Miami that could help, because part of your K08, you have primary mentors, secondary mentors, and you also have a review panel. So people that are going to meet with you regularly and review and make sure you're meeting your milestones and progressing that along. One of the problems in my first rejection is they thought that Dr. Hare was a little bit too outside my field. And it's important to have people inside your field and outside your field. And in my second submission for K08, I included Dr. Tovarek because he has more experience with endothelial cells. Dr. Hare has more experience with endothelial cells. So on top of that, my chair and I had quite a few meetings with Dr. Levy where he, I really have to give him a lot of credit for keep giving me sort of positive affirmations. Oh, another rejection. Don't worry about it. Keep working on things, keep progressing, because these things are very disheartening. But these meetings with Dr. Levy, with him helping me, push my research along, connecting with me with people both in neurosurgery and outside of neurosurgery that would help push my research along. I mean, these things were really critical, and I can't thank these people enough. I mean, I have a whole nother talk that I really need to give that thanks all the individuals and goes into really all the elements of how all of them were so critical to helping push my research along and helping me. Dr. Talmas was another one. Some of the feedback I got that was negative on some of these grants. So I went to the Mayo Clinic and learned more about how they do their rabbit experiments, what they failed on, how they do their histology. So some of these people I visited as a resident to learn more about skills that I didn't have, and some of them I visited as an attending, again, to continually learn about their skills and techniques. So this is what the front page of a KO8 grant looks like. And, you can see here, it's not, there's really very, it's a lot less about Robert Stark. It's all these other things. So you have your advisory committee. You can see these 4 people here. I had an offsite advisory committee. You can see these 5 people here, and then my 2 mentors. And so, I think when I was thinking about my job, I thought a lot about this type of stuff. And so if you're a resident thinking about applying for a KO8, this is important stuff to think about before you get to whatever institution you're going to. So this is my son when we were looking at and thinking about jobs and where we were going to go, because originally there was a lot of thought that I would just stay at University of Virginia, and he found this little patch of sand in University of Virginia. But, a major reason that I took the job at University of Miami was this type of infrastructure. This is the top floor where, when we were talking about a potential job at Miami, I was thinking about, well, where would my research be? Where would my lab be? And that was, having great talks with Dr. Levy and other key personnel to figure out what my research would look like and where I would actually be done. So downstairs, we have MRI, angiography. We just put in CT scanner, ultrasound. That's all for large animal research. And so when the NIH sees this type of infrastructure, they are much more interested in supporting your research in your lab. So that was critical to me next to operating rooms. So another element of the KO8 is, what does your practice look like? Because you need to have 50% protected research time. So for me, when I was looking at job, it was important. I was very lucky to have such amazing partners in cerebrovascular field so that I'm not Q1 call. And you got to think about that, when you're structuring your KO8. And this actually should go into the grant, how you're going to manage your time. On top of that, I'm lucky to have amazing fellows, incredible residents. And this really helps to get this research accomplished, both so that I can step away from the operating room, but also to have people that help me with this research along the way. So a lot of that was trying to balance, my clinical practice, which was challenging. And you've got to think about, I think I was doing about 550 cases a year, how you're going to work that into your KO8, because the KO8 is 50% protected research time. So that could be 20 hours a week if you work a 40-hour work week, or 60 hours a week, or 70 hours a week if you work 120 or 140 hours. So the NIH doesn't really care how many hours you work, but you've got to have a plan as far as how you're going to do that and how many hours you're going to put into this. And, for me, a lot of that was working at times when a lot of other people are sleeping, when my kid is asleep. But so your KO8 score is divided into these 3 groups, and, mentor, the infrastructure, your plan, and then your research. And you can see here, these were some of my scores on the first thing. So I did get ones. 1 is a perfect score on some of these things, like environment and institution. So that's incredibly important. My understanding was a 1 is on the order of someone that would be getting a Nobel Prize. A 10 is someone that's going to have a really hard time getting funded in every specific area. And so you can see here, I basically got 1s to 10s across the board. But I had amazing mentors, a great, amazing infrastructure. But where I was really getting crushed on was my career development plan. And that was really, they send you 20 pages or so of sort of critiques, and it's very crushing to read through all these weaknesses and figure out, how am I going to revise this and do better? But really, for me, it came down to weaknesses in my career plan. And that was because they thought I already had most of the skills that I was proposing to learn as KO8. Part of the KO8 is, what skills are you going to attain that are going to make you a better scientist? And so once I got these failures back, I started working on a KO8. and simultaneously working on an R01, because a lot of these critiques were, you already have these skills, you've already have high level publications, maybe you're past a KO8. So my plan was keep working on a KO8 and keep working in R01 and just keep banging my head against the wall. So I started working on other collaborators in other fields. I added Dr. Tobarak, Dr. Sanjoy, Dr. Pedron Vasquez, Dr. Lemon, so other really key collaborators. I worked more with collaborators in companies to develop other things that I didn't have and overcome a lot of the challenges that I was facing, which were, money, balancing my clinical practice, managing clinical research administration and support, and then basic science administration and collaterals. And while I was doing that, I kept publishing. So working on other publications to support my research. Then I submitted an R01. I'll speed this up a little bit because I see I'm a little bit behind, but I got annihilated on my first R01. An impact score of 50% is almost to the funding line where they don't review your R01, meaning you don't even get a critique back. They just tell you this doesn't get reviewed and you don't get any feedback, which is very damning. Somebody on that review board must have had some inkling of feeling like we should give this guy a shot, because even though the percentile was 53%, they still reviewed it. And so you can see this was my score, which didn't really fit with that percentile. You can see here a lot of 2s and 3s, and then a couple 6s. And that's really more of a score that you would see in someone who's a lot closer to getting funded. And part of that was some key problems in my R01. Part of that was they didn't like the funding mechanism and group that I was applying to within the NIH for funding. Within the NIH R01 study sections, there's like 100 study sections. So you have to submit to the one that's most relevant for your work. And they felt I was not submitting to a study section that was good for this grant. And so they annihilated in this study section for that reason. So again, 20 pages of critiques. And so what I did was I took every one of these weaknesses, wrote it down. You've got 10 patients of weaknesses, and tried to work on these weaknesses and how I was going to address them. So that means new experiments, coming up with new experiments specifically to address the weaknesses brought up by those study section members. So each of these experiments, and then again, publishing. So publishing experiments to show the reviewers that I can address their critiques. It's the same thing that you do when you get a manuscript with a lot of negative criticism from reviewers, but then you work on those reviewer comments and you resubmit it. So working on new mice, discussing with my friends, Mike Levitt, awesome friend, amazing scientist, wrote this on Twitter. And so, I really put this in as again, a thank you note, because incredibly humble person, but he reviewed my R01s. I read his R01s. I mean, he was integral in the success of my R01 because of the feedback that he gave me and from learning about his successes and failures. Again, getting a CTSI grant and then putting together a new R01 application while I was putting together a new KO8. All these red lines that you can see here are modifications and changes in key experiments. So then I got my R01 score back. This is within the funding range for a new early stage investigator. So of course, celebration time. And I think it's important to celebrate your victories every once in a while. So, maybe we took a day or two off to take a trip and celebrate. But then, what are going to be the next steps? How are you going to get these experiments done? And how are you going to keep building? So I started continuing to plan and look forward for other people that were going to help me for my future studies, for developing another R01, looking at new imaging. I'll push this forward a little faster, looking at new materials, collecting of new cells, other grants. We just got a grant on smoking, which is relevant for this. And all this looks forward for future clinical trials. So imaging, medications, and then also new surgical and endovascular techniques. And through all this, I don't have the recipe for this, but it requires balance, certainly something maybe I used to have, but I don't have a lot of great balance now. And it's balancing your science with teaching, with, you know, being a good friend, with, you know, being good with your family. And, you know, this is my son stealing my cell phone. So he likes to go out at, you know, 5 in the morning and make these videos, and then also, you know, being around to put him to sleep. And so I don't have the magic recipe certainly for any of this, but, you know, it's going to require balance between your friends, your family, your clinical practice, and then the research as well, if you're going to do neurosurgery and pass this on. So sorry, I had to speed up. You know, happy to meet with anybody if my failures can be, you know, helpful in your path. And hopefully, you know, for the residents and students, we'll be celebrating, you know, all of your victories, no doubt, short enough and more in person. So any questions with all that that I can answer or maybe help with?
A great job, Bobby. I think you have done incredible. I mean, you should be congratulated for congratulating your mentors throughout that talk, but really this has been an incredible journey for you. And I think the take-home message is, you know, how can I be like Mike? I mean, how can you recapitulate it? And it's, as you said, it's just a lot of hard work and getting back up after getting punched in the gut. And so again, congratulations.
Yeah, thanks so much. And thanks so much for all of your help. You know, you know, saying it daily would not be, you know, enough. So I, you know, really appreciate it. Awesome. Well, you know, if any of the students or residents, you know, if I can help with any of this stuff, let me know. You know, I think the R21 is an amazing pathway for you guys. It's great to see a number of the residents getting success in the NIH R21 pathway to develop your research, and awesome.